Hello, everyone. Thank you very much for joining us today for OxPal's inaugural Medical Research Conference. We're really glad to see you all here. My name's Aisha Musa. I'm a fifth-year medical student at the University of Oxford and the current director of OxPal. OxPal is a student-led organisation that connects doctors and medical students in the UK with their Palestinian counterparts to complement local medical teaching and deliver a range of educational opportunities. Our organisation is apolitical. We are motivated by a strong passion to ensure every clinician and future clinician has the opportunity to fulfil their potential irrespective of geopolitical barriers. All of our speakers are external to our organisation. Views expressed are their own, but we are gratefully thankful to them for generously volunteering their time to help us achieve our goal. On that note, I'm delighted to introduce to you our first speaker, Sir Iain Chalmers. Sir Iain has made incredible contributions to advancing international policies on health research and evidence-based medicine. He is currently a coordinator of the James Lind Initiative and one of the founding members of the Cochrane Collaboration. His impressive clinical experience includes practicing as a clinician for 2 years in the Gaza Strip, upon which he will reflect today. It is my pleasure to hand the floor over to Sir Iain to open our conference.
Thank you very much indeed, Aisha, and thank you for the invitation to come to this important initiative that you've taken in organising a conference on medical research. And I hope that the conference will be a great success. In your initial approach to me, you asked if I could speak about the importance of evidence-based medicine. And I had to have a consultation with you because I haven't been a clinician since 1973, believe it or not. And I didn't think I had any credibility in talking about evidence-based medicine from the point of view of people who are actually delivering care. So we agreed on a different, having had a discussion about what I had thought of talking about, we agreed on a different title, Trying to Do More Good Than Harm, and the influence of having spent 2 years working in Gaza had on that general objective. So thank you for accepting that. I hope I don't let you down. As you know, Aisha, I'm very nervous, and so I'll try to live up to your expectations of me. So let's get going. See whether these slides will work in the way that they should do. All right. There we go. So to start with, the lessons that I learned while working for 2 years in Gaza and Palestine, they were 1969 and 1970, so a long time ago. Why Palestine? Why Gaza? Well, it happened curiously because I had failed second MB, the second MB exam, failed the physiology part of the exam, and was able to take it a resit 3 months later. But that meant that I was out of kilter with the start of the clinical assignments. And so I had three months over which I could do whatever I wanted, I guess. And it happened that I was in a hall of residence and a couple of rooms down from a Palestinian from Bethlehem. And he said, well, why don't you go to Palestine and visit my family in Bethlehem? So I did that, and it was a very important experience. Let me see whether, there we go, whoops. And there's a picture of Bethlehem these days. As many of you may know, that's where the Church of the Holy Nativity is. However, while I was, while I was on this journey down there, I read this book by Edward Atiyah, who was a Lebanese historian called The Arab. As you see, it's a Pelican book. And what was shocking to me was his account of what Britain's responsibilities are for what has happened to the Palestinian people since 1917, where this letter was sent by Balfour, the Foreign Secretary at that time, to the Lord Rothschild, who was head of Anglo Jewry, as it's referred to, Jews living in England. And it has this letter. I'm going to read it because it's so important to the history of this whole area. His Majesty's government view with favor the establishment in Palestine of a national home for the Jewish people and will use their best endeavors to facilitate the achievement of this object, it being clearly understood that nothing shall be done which may prejudice the civil and religious rights of existing non-Jewish communities in Palestine, or the rights and political status enjoyed by Jews in any other country. Given that 90% or more of the population was non-Jewish, it was a very curious way of referring to the population of Palestine. What we have seen since 1917 is a gradual erosion of the rights of the indigenous people of Palestine, Palestinian Arabs, some of them Jewish, in fact, many of them Muslim, and many of them Christian. And over time, these maps demonstrate very graphically, I think, Britain's betrayal of their undertaking to the Palestinian people in 1917. This meant that there were opportunities to deal with certainly my shame at this duplicitous role in Palestine by applying to work in Palestine. And I made my application along with Jan Skidmore, who is a senior staff nurse. And it has to be stated fairly unambiguously that the motivation for going there was political more than it was medical. It's that we felt that the Palestinians had been badly served. After the 1967 war, there was a shortage of doctors and nurses available to the United Nations organization, which has responsibility for providing services for Palestinians. And we applied to them to work there in Palestine. It's called UNRWA, the United Nations Relief and Works Agency for Palestine Refugees. This was the annual report of the Director of Health for the first of the 2 years we spent there, 1969. The map on the right shows you where this tiny little strip, it's about 30 miles long. It is between 3 and 5 miles wide. At that time, the time that we went there were 400,000 only people who had occupied that strip. There are now over 2 million. Here it is, and up at the top of the strip, Jabalia camp is where Jan Skidmore worked. Gaza City was where we both resided. And down the bottom, I worked in Khan Yunis camp. These days, if you go to Gaza, it's high-rise buildings all over the place. If not high-rise buildings, then the rubble that has been created by Israeli airstrikes on buildings with little regard to whether there was targeting of military targets. So this is what much of Gaza looked like. On the top right-hand side, you see a picture where you see that it's on the coast at the eastern end of the Mediterranean. Here's an example of a demolished building. If someone was convicted of having been part of the Palestinian resistance to Israeli occupation of the Gaza Strip after the '67 war, then it was not uncommon for the whole of their family home to be demolished. And they did this under the umbrella of a British law. And that British law is still functioning today in the demolition of houses in the Israeli-occupied Palestinian territories. Here's a picture of Jan working in the clinic in Jabalia. On the right-hand bottom side, someone is pointing to a hole in the window, a bullet hole in the window. And Jan had been working and examining the belly of a pregnant woman when the person she was examined rolled off the couch and pulled her down with her. And moments later, this bullet went through where she'd been standing. Here's an example of the clinic that I was working in. This particular one was a rehydration and nutritional rehabilitation clinic. By the way, the size of the camp, there were about 40,000 or a little bit over 40,000 people in the Khan Yunis camp. And malnutrition was happening from things like this. This is a little baby with a hydraulic brake fluid bottle, a narrow top so you couldn't clean it properly. And almost certainly there had been an attempt to look after this baby by giving artificial milk. This inappropriately named Belgian version is safety milk. So the milk powder was mixed up usually with difficult to clean waters, and needless to say, causing diarrhea and failure to thrive. I did a sick child clinic every morning, and because it was extremely slow when I was trying with my very inadequate Arabic to run it, my dentist colleague, Levon Wahid, sitting there, helped me out with translating. Now, this poster on the left was actually made at the end of 1968, just before I left to go to Gaza. I never saw it on the billboards that it went on, but it was a fundraising poster for the United Nations Association. And as you see, it says, "This do-gooder needs your help." The do-gooder, by the way, is me. I look very different now, very much more decrepit now. What was the most important lesson I learned in Gaza? Well, first of all, that do-gooders can sometimes do more harm than good. And as a result, I now suffer from what I regard as chronic, incurable skepticemia. I could have served my Palestinian patients and their community better if I had had greater humility and willingness to admit uncertainties about the effects of policies and practices. So the second part of this talk is recognizing the need to identify and acknowledge treatment uncertainties. You probably didn't expect to see a picture of Donald Rumsfeld. For those of you who had any idea, he was the Secretary of State during the wars, American invasions of Iraq. And this is perhaps his only credit-worthy contribution to history, defining different types of uncertainty. He distinguished known knowns from known unknowns to unknown unknowns. And it's a useful way of seeing things. So I want to use as an example to illustrate these different things, whether or not to give prophylactic antibiotics for measles. And some people think this is a known known, the answer. Some people think it's a known unknown. So let's go through it. Measles remains very important. Between 30 and 40 million people a year develop measles, and 500,000 of those die from the disease. And it's associated not just with acute problems, some of them deafness, for example, but also chronic complications including malnutrition. And here's a little baby who had an attack of measles about here. I'm afraid you don't see it very well, and catastrophic decline in weight, and then basically undernourished right up to the age of 2, when they would have gone on to a different monitoring system. So my question to myself was, should I have done in Gaza what I'd been taught to do at medical school, which was don't give antibiotics to people with viral illnesses such as measles? My Palestinian colleagues often disagreed. Here's someone who was working in the same clinic as me, Dr. Hassouna. He gave prophylactic antibiotics as a routine to children with measles. Years later, I learned that by the time I went to Gaza in 1969, there was evidence from 6 controlled trials suggesting that antibiotics given prophylactically to children with measles can reduce the incidence of pneumonia and other complications of bacterial superinfection. This is the first one of those 6 trials, published in 1939 in the BMJ. Some people think that controlled trials didn't start until 1948. Well, this is just one of many examples. There were good controlled trials going on before that time. So they say the case in this report, the cases were allocated in order of admission, alternately to 2 groups. The first, or control group, received the usual nursing and expectant medical treatment. The second group received, in addition, sulfanilamide. There's evidence that that drug, the sulfanilamide, I beg your pardon, is of value in reducing the incidence of complications. And these come from bacterial superinfection on top of a viral disease. Quite a few years later, in fact, I was still being irked by this situation of uncertainty about how to manage this situation. So I wrote an article for Pediatrics, in fact, at the editor's suggestion. And he pointed to a World Health Organization meeting convened in 1993 to decide on research priorities for the treatment of measles. Highest priority was accorded at that meeting to additional controlled trials of prophylactic antibiotics. Fair enough, the ones that, the 6 that I referred to in this same piece, they weren't all universally well done. So it's perfectly reasonable to ask for more evidence. But it did take a long time. It was very important, given the high morbidity associated with measles and mortality, that this was addressed. Well, 13 years after that 1973 meeting, a randomized trial was done in Guinea-Bissau, and what it showed was the group that received the prophylactic antibiotics had less pneumonia and conjunctivitis and had significantly higher weight gains in the month. However, there was a Cochrane review taking the evidence from reasonably controlled trials as best they could, and that review suggests a beneficial effect of antibiotics in preventing complications. But it wasn't possible to give very definitive guidelines, which type of antibiotic for how long and so on. And therefore, there was a need to generate more evidence. Now, you would think that in a disease as important as this, that WHO would by now have acted on its 1973 conclusion. So we have quite recently, 2 years ago, a guide for clinical case management and infection prevention and control during a measles outbreak. Prophylactic antibiotics are not recommended. Distinguishing viral from bacterial infection is often not clinically possible. Early empiric antibiotics in patients with suspected superinfection should be administered aggressively, having said that it's difficult to know when to diagnose bacterial superinfection. But then it gets back to its starting place, administering universal antibiotics to all patients as a preventive measure isn't recommended. Well, isn't that helpful? So, what do other people say? Well, as it happens, less than a month ago, there was a seminar published in Lancet about measles. What did they conclude? Having referred to the WHO document, all patients should be carefully and regularly monitored for secondary infections to ensure that timely and effective antibiotic treatment can be given. Don't go into details of how you identify bacterial superinfection with confidence. The administration of prophylactic antibiotics is not recommended. And note that neither the WHO nor the Lancet seminar referred to the Guinea-Bissau randomized trial or the relevant Cochrane review. Neither did either of them call for additional research to address continuing uncertainties. So we've got this situation where every year 30 to 40 million people develop measles, more than 500,000 of them die, and millions more suffer chronic complications without clear evidence. I believe that some children developing measles in Cairn units, and when I was there, suffered and probably died unnecessarily because I had withheld prophylactic antibiotics, reflecting what I had been taught at medical school and during house jobs. What were the lessons I began to learn in Gaza? That good intentions aren't enough. Professional humility and admission of uncertainty are preconditions for protecting patients and the public. In retrospect, it's clear that I would have served my patients better if I had had access to reliable, up-to-date, systematic reviews of relevant research and clinical guidelines based on them, and opportunities to integrate needed additional research within routine clinical practice. Third part, learning how to use research to address treatment uncertainties. Well, I thought I ought to pay some tribute to the large number of people in what I gather will be the audience to information in Arabic. And it's to remind you, if you knew already, that some people recognize the importance of controlled comparisons more than a millennium ago. And Abu Bakr Muhammad ibn Zakaria al-Razi, I have in mind a long time ago. There's a document in the Bodleian Library which records his writing. And this is a key bit. I'm not going to leave it on the screen for a long time because I can't translate it at sight. I don't read Arabic at all, but I'm going to give you the key bit. He was considering how to manage cases of meningitis, neck stiffness, photophobia, fever, headache, lassitude. And he said, when you see these symptoms, then proceed with bloodletting. For I once saved one group of patients by it, bloodletting, while I intentionally neglected to bleed another group. By doing that, I wished to reach a conclusion. In other words, he knew that a comparison was needed, and that he doesn't say whether it was a concurrent comparison or at other times. And I'll show you later on the way to look at more material in Arabic from the medieval period, which is relevant to our interests today. We need to confront important uncertainties about the effects of treatment, because otherwise patients will be denied beneficial care, will be given harmful care, and resources will be wasted on useless or unnecessarily expensive care. Differing opinions and uncertainties about the management of measles is just one of hundreds of everyday examples of varying opinions about the effects of clinical and public health interventions. And in the early 1960s, I hadn't learned how to judge which opinions were most likely to be trustworthy. I was a liability, in other words. This man, as I'll show later in this talk, was very influential. He opened my eyes to ways of getting out of this jungle. And he said in a later publication from the one I just shown, it's surely a great criticism of our profession that we haven't organized a critical summary by specialty or subspecialty adapted periodically of all relevant randomized controlled trials. Does it bring any initiative to mind? The Oxford Textbook of Medicine, for example, in its second edition, concluded that the clinical benefits of thrombolysis remained to be established. By then, there was a massive amount of evidence subsequently shown. Well, actually, at the time this was published, the Oxford Textbook of Medicine, that if you looked at all of the trials systematically in a review, there'd be no doubt in your mind that you would want to have thrombolysis if you were admitted to hospital with a myocardial infarction. I gave evidence to the House of Lords Committee looking into medical research and said that the failure of the Oxford Textbook of Medicine to pay attention to this evidence was lethal, and found myself quoted on the Sunday Times the weekend after. And as you can imagine, there were a lot of rather unhappy people in Oxford that I had drawn attention to this misleading judgment by an author of the Oxford Textbook of Medicine. He went on to do great things, didn't affect his career at all. But this started to teach me that it was actually quite important to look systematically at controlled trials and other types of research. And this is an example drawn from a systematic review of whether it's worthwhile giving corticosteroid drugs to people expected to deliver their babies preterm. Damn it. And it's been the first 7 trials of what ended up being around about 20 trials at that time made clear that it was a very important way of reducing morbidity and mortality of prematurity. Now I'm going to run a video now. I'm going to try to anyway. And this lasts about 10 minutes, and I'll come back to you a bit later.
In October 1993, approximately 80 like-minded individuals working in healthcare around the world gathered at the Summertown Pavilion on Middle Way in Oxford, UK.
We wrote as late as July, inviting people to come to what we called a first colloquium in October. And we didn't promise them any travel. We said we'd give them sandwiches and coffee, but that was it. They'd have to find the funds, and they came from all over the world.
It was organised in quite a rush, and there was a lot of people from all over the place, not quite knowing what it was all about, but all anxious to move forward. And it was a very energising and powerful meeting.
For 2 days, the group discussed how they should organise the working structure for what would become the Cochrane Collaboration, an international effort to improve healthcare by finding and promoting the best possible scientific evidence.
So when I came back from the Middle East, I read a book by someone I hadn't heard of up until then, called Archie Cochrane, Effectiveness and Efficiency, Random Reflections on Health Services. He asked the question, how can we have a rational health service if we don't know which of the things being done within it are useful and which are useless or possibly even harmful?
In his book, Archie Cochrane drew attention to randomized trials.
I'd never heard of randomized trials. I'd been 6 years qualified. I'd never heard of it. And so I started to look into this. And basically, it was like getting a compass in a jungle of conflicting, incompatible clinical opinions about how to practice. And so that started me on the trail of looking for reports of these studies in the field which I had chosen to work in, which was obstetrics.
Starting around 1974, and for the next 10 years, Iain and a team of about 100 people would search out relevant reports of randomized trials in obstetrics.
Also, looking at the possibility of analyzing similar studies together so that one can start to address the way that you're misled by the play of chance. Now, I didn't know that round about that time, Jean Glass named that process meta-analysis. But in fact, that's what I was describing in this outline proposal for this work. And whereas other people were doing it for specific treatments, we were completely mad and ambitious and decided we ought to try to do it for all of a specialty, for the whole of obstetrics.
This work culminated in a 2-volume, 1,300-page publication, as well as a paperback for consumers to give them access to this research.
I was a member of the National Childbirth Trust, and I remember Iain Chalmers coming to give a presentation. And I remember very clearly being aghast because this presentation was about a review that showed a particular suture material causing more painful intercourse for women 3 months after birth. And yet he said lots of hospitals were still using it, and I was just incensed, really.
We realized that the books would be out of date when they were published. All books are. So we started publishing electronically in 1988. It was called the Oxford Database of Perinatal Trials. It was that electronic publishing vision that made it possible to conceptualize what the Cochrane Collaboration might do if there was sufficient support for it.
I remember the editorial in the British Medical Journal calling for people to collaborate. And I was in a hotel room in Lahore and wrote to Iain saying it was very important that this initiative that he was setting up, the Cochrane Centre as it was then, included problems from developing countries and people from developing countries in the process, because sometimes both of those get forgotten.
We left people in no doubt at all that if this was going to be done, it needed international collaboration. We'd demonstrated with the model of the perinatal work that it was possible to do it. Our job was to facilitate. So if that facilitation was going to happen, we needed to get in touch with all of our allies around the world and to say, are you up for this?
Many doctors were resistant to the idea that you could combine the evidence from different trials that address the same question. They were all saying our trial is special. You can't combine it with any other trial.
Nobody knew what a systematic review was. And in fact, they were kind of distrustful. It's like, well, you didn't do any research, you just read some studies. When we did our first review, I wasn't able to convince very many people to stop using antibiotics based on a Cochrane review. Whereas now, as I say, it's part of the quality criteria.
What has changed over the last 20, 30 years is the recognition that you can usefully combine trials that have addressed the same or similar questions to work out whether or not treatments work.
It was actually all about, only using interventions when they were effective, and it proved that a lot of the routine interventions that had been around before actually just didn't work or had adverse effects. And so they eventually were stopped. Routine shaves, routine enema, routine episiotomy, they've all gone now.
Within, I think, about a year, we'd found 400,000 trials that had been in Medline but had not been indexed. And there was the equivalent of billions of dollars worth of research that you couldn't find. So the best search in the world could only find 13,148 trials when there was probably at that time 350,000, 400,000 trials in Medline, but just unfindable.
And there also been for many years concern that not all trials are published. And so how do we find trials, period, that have been initiated? And so there's been a group working over the years saying we really need trials registration, But to be honest, it's always been a small group, academics saying these things in print, but didn't really get anywhere. And I think Cochrane's being behind trials registration and amassing a really large and meaningful register of published trials itself made a difference that we now have trial registration worldwide. So for me, one of the most important things we've done has had to do with getting all the clinical trials in one place.
Clinical practice guidelines were relatively novel in the early 90s, and now we're doing an exercise within the stroke group. All the Western clinical practice guidelines are similar, and they've all referenced Cochrane reviews in large numbers. And so it's become kind of embedded in the normal practice of quality improvement.
When I go to international meetings on obstetrics and gynecology, without a doubt, people are quoting Cochrane reviews probably in every presentation on evidence or what's best practice or guidelines.
Have I seen in the last 20 years as to whether people with schizophrenia are getting better care? Yes, I think I have. It has a huge journey yet to go, enormous. But what didn't used to be there is accessible evidence that can be used either by policymakers or people with schizophrenia themselves, or the clinicians, the busy clinician.
We established the South African Cochrane Centre. We made it a very clear goal that we would prioritize the conditions that are important to Africa. We worked very closely with the collaborative review groups. We have together been able to substantially increase the number of reviews that are relevant to Africa.
One of the major achievements has been to convince people that really accumulating evidence is essential. This was very much Archie Cochrane message.
I think that when Cochrane said that evidence about healthcare should be brought together and synthesized so that all the evidence would be available, now it seems to us obvious. But actually at the time, it wasn't at all obvious. And this was a new idea that Cochrane was delivering that was in a way a challenge to the medical profession. Get on and do this.
So to take up approximately where that Cochrane Collaboration video left us, one of the people that inspired Archie Cochrane was this man, Austin Bradford Hill, the most famous British medical statistician of all time. And he made a very important point, quite simple point, that he felt there were 4 questions to which readers of research want answers. Why did you start? What did you do? What answer did you get? And what does it mean? This meant that you had to consider, let me try and, yep, there we are. There need to be critical appraisals of claims about treatment are needed to inform both policy and practice and the design of additional research. Well, I introduce now my first Palestinian example of someone doing this. He'll be speaking at tomorrow's meeting, my very good friend, Khamis Alessi. And you'll see that the second of the 3 publications there, the Lancet, all of them in the Lancet, was about promoting critical appraisal skills being more important than promoting research in Palestine. And I agree with him, and I suppose I wouldn't be a co-author if I disagreed with that main message. And as a consequence, he, having set up the evidence-based medicine unit in Gaza under the aegis of the Islamic University back in 2011, has done a tremendous amount to raise people's awareness of the issues that they need to consider in terms of healthcare. Systematic reviews are relevant beyond their application in analyzing controlled trials, which is where they're usually shown. This, for example, is a cumulative meta-analysis of the results of case control studies. Cumulative means that you start with the first case control study, you abstract information from that, and then you add, when the second one is done, to provide an overview of those two. And as you'll see from these examples, it comes down to something being four times as likely to be associated with a death in infancy as a control group with no death, survivors, in other words. And this information, in fact, refers to the positioning of a baby when the baby is put to bed. In this book, the most widely recommended handbook for parents ever published, Dr. Spock's Baby and Childcare, he says, I think it's preferable to accustom a baby to sleeping on his stomach from the start if he's willing. He may change later. A systematic review was done of the case control studies, looking at the extent to which position of a baby sleeping was a risk factor for subsequent unexplained sudden infant death, crib death it's sometimes referred to. Their conclusion was advice to put infants to sleep on the front for nearly half a century was contrary to evidence available from 1970 that this was likely to be harmful. Systematic review of preventable risk factors for sudden infant death syndrome from 1970 would have led to earlier recognition of the risks of sleeping on the front and might have prevented over 10,000 infant deaths in the UK and at least 50,000 in Europe and the USA and Australasia. Now, I forgot to mention, and I am sorry that I'm late in mentioning it, Aisha asked me to, if people are sensitive, they may not wish to look at this picture of a case report, which some of you may recognize as the result of phosphorus burns. Phosphorus was used during the 1978-79, I beg your pardon, 2008-2009 assault on Gaza. Here's phosphorus being rained down on the population and being indiscriminate in terms of who it affected. These very nasty lesions were, as you can imagine, that there was a bit of live phosphorus boring its way down into the soft tissues of the person on whose skin it had lasted. Very difficult to see the pieces of phosphorus and make sure you've taken them all away. And if you didn't do that, what you might find is you sew up one of these lesions, only to find a few hours later that smoke was coming out because the thing was still alive. Horrible condition. So here's my second Palestinian co-author of this presentation, Loay Barhouni. He wrote that up as a case report, which was published in The Lancet. And then he went on to do a systematic review of interventions for treating phosphorus burns. And he got a prize for his work in this area from the National Conference on Trauma Medicine. He's currently working in Queensland, and he's made an enormous success of his young career. And one of the things that he did was to lead a survey of the quality of medical and public health research from Palestinian institutions. Just to make a point very strongly, systematic, up-to-date reviews of research on the effects of healthcare are essential, although not sufficient for improving policies and decisions in healthcare and research. You need to take into account, as well as the evidence from research, the needs that have to be met, the resources that are needed to meet those needs, and the priorities, because there's never enough resources to go around everything. And those are the things that people who are making policies and decisions in healthcare need to consider. In other words, systematic reviews do not speak for themselves. They have to be interpreted in the light of other information. So one of the reasons that Kamal Mahtani, the co-director of the Centre for Evidence-Based Medicine in Oxford, suggests that all health researchers should begin their training by preparing at least one systematic review. That experience almost always leads one to recognize deficiencies, quite common deficiencies within reports of research, and therefore very influential on how confident one can be in the conclusions once one's considered the quality of the evidence that goes into it. It's an important paper. This paper is the fourth of an audit of the controlled trial reports published in BMJ, Lancet, New England Journal of Medicine, Journal of the American Medical Association, and the Annals of Internal Medicine, each taking all the trials published during the month of May in those years. There have been subsequent ones as well. But what they show basically is that the need to, at the beginning of a report of a controlled trial, say which systematic reviews it had referred to in designing this trial, and when reporting that new additional trial, what difference does it make to the overview? We're going to repeat the evidence, the exercise in the month after next. I guess it'll be May coming. It's put rather more succinctly in this report from Karen Robinson and Steve Goodman. In reports of randomized trials published over 4 decades, fewer than 25% of preceding trials were cited. The potential implications of this include ethically unjustifiable trials, wasted resources, incorrect conclusions, and unnecessary risks for trial participants. A sorry situation. Now, I want to talk for a little bit about the difficulties that are faced by people living in Gaza because of the blockade since 2007. It's often referred to as the Israeli blockade, but in fact, Israel and Egypt have collaborated, if you like, on making the lives of people in Gaza miserable. One of the things that, as a result of the blockade, is that certain drugs and medical equipment can't be and aren't imported to the Gaza Strip, and the movement for medical care to places that can provide it, which Gaza can't. If you take, for example, radiotherapy, there is no radiotherapy made available within Gaza, and that's because they don't want radioactive material to be brought into the strip, or radioactive potential. This was a report from the human rights organization Al-Mazan Center, and this is an interesting cartoon film talking about the difficulties faced by Fatina, who had breast cancer, which was diagnosed late, and then she couldn't get through to get proper treatment for it, and died prematurely as a consequence of that. This situation has been reflected in Shaima Al-Wahedi's wonderful research on factors affecting survival among women with breast cancer in Gaza. She's recently submitted her thesis from her PhD candidacy. That middle report, mammographic screening in the occupied Palestinian territory, a critical analysis of its promotion, claimed benefits, and safety in Palestinian health research, is very important indeed, and published in the Journal of Clinical Oncology, Global Oncology journal. it shows that there is a totally inappropriate emphasis on population mammographic screening at a time when diagnostic services and treatment services are deficient because of the siege. Going on, what I hope to do. Here we are. Lastly, Majdi Ashur, who will be submitting his thesis to Edinburgh University during the summer. He's looking at a very interesting issue about access to healthcare in Gaza since 1948, but with particular reference to the period, the more recent period, 1987 to 2019. And it shows evidence of attempts to privatize more of the government and UNRWA care given, efforts which in fact have failed, I'm glad to say. So a message from this is that patients, health professionals, and researchers are not benefiting from research as much as they should be, partly because the research community is not routinely reviewing existing evidence systematically before beginning additional primary research, and not routinely showing what difference the results of additional research make to the totality of what is known. This was a series of articles published in The Lancet in 2008. I was very privileged to have been invited to be on the steering group for this series. It came out in terms of 5 articles. I want to draw attention to the 4th, Health as Human Security in the Occupied Palestinian Territory. And that starts to deal with the interrelation between political research and medical research and health research. They're intimately related. I don't think that it's sensible to consider considering them separately. Other people may disagree with that. But what the Lancet said that included all of those papers, that hope for improving the health and quality of life of Palestinians will exist only once people recognize that the structural and political conditions that they endure in the occupied Palestinian territory are the key determinants of population health. What responsibilities do health professionals like you and like me have to influence important social and economic determinants of health, such as the abuse of human and civil rights, wars and civil unrest, unfettered pursuit of profit, and economic injustices? People may vary in their answers to that. I know where I stand. This is one representation of a manifestation of where I stand. This was published in The Lancet in 2009. What I say at the end of the commentary, this is just the tail end of it, but I end with this sentence: for many, Israel will continue to be judged by its attitudes and actions towards the non-Jews whose lives it controls. And certainly it controls the lives of about 6 million. In summary, for patients and professionals, well, recognize that good intentions aren't enough. Decisions in healthcare should be informed by systematic reviews of research evidence, so demand systematic reviews. For the research community, pay greater attention to questions that are important to the people who use healthcare. I've put that in italics because I haven't tried to fit it in to this talk. What I have done is to draw attention to the use of systematic reviews to find out what's known already before doing an additional primary research. Another issue of great importance, which I haven't tried to cover, is the need to minimize reporting biases by publishing the results of all research before to which patients have contributed. And lastly, which I have tried to cover, set the results of new research within the context of systematic reviews of other relevant research. So the conclusion: failure to address uncertainties about the effects of treatments has resulted in avoidable suffering and death, waste of resources in healthcare and health research. Important consequences of failure to address uncertainties. Here are a couple of resources which I feel you may be interested in, and certainly they will help to promote critical thinking about treatment claims. The first is the James Lind Library, from which I drew the example from Arazi earlier on, and that has lots of material illustrating the development of fair tested treatment in healthcare. Secondly, the book Testing Treatments. There's the way that you get hold of it, and you can get hold of it in any one of 19 different languages, including Arabic. The Arabic edition is responsibility of Adib Sali, a Syrian psychiatrist who now lives and works in New Zealand. This book is freely available on the web and in all of those different languages. And it's also important because some of them, for example, the English one, there's an audiobook version of it for you to use if you want that. Also the Spanish one as well, is, I think there's an audio version of it. I'm going to end with something a little bit different. The Palestinian history tapestry is something which my wife Jan, who worked in Jabalia, started over a decade ago now. It's now run primarily by Palestinians. It's a Palestinian history tapestry which has panels relating to not only the past history, but very much the current history or current elements which will be regarded as of importance. It's quite big. It's over 100 panels. In other words, getting on for about 100 meters. And it's been exhibited in a variety of places, but you can see it on the web at that web address. And this very month, in a book entitled Our Vision for Liberation, there are contributions from engaged Palestinian leaders and intellectuals speaking out. It's the book itself is Ramzi Baroud and Ilan Pape, an Israeli, are the editors of it. And I'm very proud that together with her colleague, Jahan Al-Farra, Jan Chalmers, my wife, is the only non-Palestinian contributor to one of the chapters. And the two of them, Jahan and Jan, are talking about the Palestinian history tapestry. So I hope those of you will interested in this will go and have a look at the website. Lastly, I just want to close with an important statement by Archbishop Desmond Tutu, who died recently. Those who turn a blind eye to injustice actually perpetuate injustice. If you are neutral in situations of injustice, you have chosen the side of the oppressor. Thank you very much for listening. I'm glad I haven't gone over my hour.
Thank you very much, Sir Iain, for that talk. It was honestly amazing to listen to, and got lots of comments in the chat saying lots of people enjoyed your talk. And I think as us sat in a room of medical students and healthcare professionals, researchers or future researchers, it's some really important messages that we can take away from before we embark on our careers as well. So thank you very much for that.
Thank you, Aisha.